Carcinoma. Carcinoma occurs almost exclusively after the age of 50. Thus, Judd classes his 93 operated cases by decades from 50 to 90 years as 21, 34, 36, and 2 cases. He has seen a few cases before 50. The symptoms of the disease usually begin a decade later than those of prostatism. Pathology. The tumor is either medullary or adenocarcinoma. It may occur alone or in conjunction with prostatism. Garrity found both in 75% of his pathologic material. It has been supposed that prostatism was the cause of prostatic carcinoma. This opinion was fostered by the absence of precise knowledge of the pathological differences between prostatism and carcinoma, which led such competent observers, for instance, as Albaran and Halle, to estimate that they found evidences of carcinoma in 14 out of 100 cases of specimens of supposedly non-malignant prostates removed at operation. These so-called carcinomata were found in the midst of adenomatous tissue and have no bearing upon clinical carcinoma of the gland, for pictures closely resembling carcinoma can be found in many non-malignant pseudoadenomata. But they are confined to isolated sections and do not appear clinically as carcinomatous. To Garrity, we owe the laboratory confirmation of the fact which has long been clinically evident enough that carcinoma and prostatism have no direct relation to each other. He has shown that if we leave apart these minute growths, which might be called laboratory carcinomata, and consider only those that are grossly carcinomatous to such a degree that the pathological condition can at least be recognized in a gross section, the carcinoma begins in a portion of the gland not affected by prostatism or adenomatous change. Footnote, McGrath does not wholly accept this contention. Carcinoma, therefore, has only this relation with prostatism that where the one begins, the other does not. Prostatism affects the lateral lobes and posterior commissure, as we know. Garrity found 1 carcinoma originating in the anterior commissure and 49 originating in the posterior lobe, that part of the prostate which lies below the ejaculatory duct and is never affected by prostatism. This posterior lobe extends from one side of the prostate to the other. It is thickest at the apex and thinnest at the base. It therefore lies between the examining finger and any other portion of the prostate, and if it is carcinomatous, it is impossible to distinguish by rectal touch whether the carcinoma is in the lateral lobe or elsewhere. One can only feel the presence of a hard nodule. The neoplasm extends in 2 directions. It first follows the ejaculatory ducts, breaking through the upper border of the prostate. Thence, it slowly invades the trigone, but extends rapidly up between the bladder and the seminal vesicles, extending toward the lateral walls of the pelvis in the sheath of the vesicle, so that the palpating finger from the rectum feels what seems to be a thickened and indurated vesicle, while at the same time the extension through the upper border of the prostate can be felt as a hard ridge along this. Figure 66. Figure 66, sagittal section of prostate illustrating origin of carcinoma. 1, posterior commissure. 3, verumontanum. 4, anterior bladder wall. 6, fascia of Denonvilliers. 7, utricle. 8, posterior lobe, where carcinoma usually begins. 9, trigone. 88, anterior lobe. 0, urethral orifice. In the second place, the carcinoma extends into the lateral lobe of the gland itself, perhaps invading and replacing the lesions of prostatism there. The fascia of Denonvilliers effectively prevents the extension of the carcinoma to the rectum until very late in the disease. The growth reaches the surface of the urethra and the bladder somewhat more readily, but even this progress is slow compared to its extension within the pelvis. It is not uncommon for the carcinoma to cause retention of urine while no ulceration is present and no hematuria has occurred. If rectal stricture occurs, this is likely to be high up about the upper extremities of the seminal vesicles. The pelvic and lumbar glands are involved early, so early indeed that the patient may die of glandular involvement or other metastasis before the carcinoma of the rectum has grown to sufficient size to be noteworthy. According to Bloomer, bone metastases occur in 2/3 of the cases that are not killed by operation.